Here's an article called Combining Knowledge and Data-Driven Insights for Identifying Risk Factors Using Electronic Health Records. Here's the abstract. The ability to identify the risk factors related to an adverse condition, for example, heart failure, diagnosis, is very important for improving care quality and reducing cost. Existing approaches for the risk factor identification are either knowledge-driven from guidelines or literatures or data-driven from observational data. No existing method provides the model to effectively combine expert knowledge with data-driven insight for risk factor identification. We present a systematic approach to enhance known knowledge-based risk factors with additional potential risk factors derived from the data. The core of our approach is a sparse regression model with regularization terms that correspond to both knowledge and data-driven risk factors. The approach is validated using a large data set containing 4,644 heart failure cases and 45,981 controls. The outpatient electronic health records for these patients include diagnosis, medication, lab results from 2003 through 2010. We demonstrate that the proposed method can identify complementary risk factors that are not in the existing known factors and can better predict the onset of heart failure. We quantitatively compare different sets of risk factors in the context of predicting onset of heart failure using the performance metric, the area under the ROC curve. The combined risk factors between knowledge and data significantly outperform knowledge-based risk factors alone. Furthermore, those additional risk factors are confirmed to be clinically meaningful by a cardiologist. We present a systematic framework for combining knowledge and data-driven insights for risk factor identification. We demonstrate the power of this framework in the context of predicting onset of heart failure, where our approach can successfully identify intuitive and predictive risk factors beyond a set of known heart failure risk factors. Introduction. Heart failure has become increasingly prevalent and is among the most costly diseases for Medicare patients. The annual direct cost is $33 billion. The prevalence and cost trends will continue to rise unless novel and cost-effective strategies are developed to better manage the disease. While hospital admissions and readmissions are being reduced, the cost benefit is modest, self-limiting, and too infrequently does little to improve patient quality of life. The persistent challenge is the failure to detect heart failure at stage that is early enough to implement proven lifestyle and pharmacological interventions that can delay and possibly even prevent disease progression. The ultimate goal of our study is to develop robust, valid, and practical means of early detection that can be applied in primary care practices that use electronic health records. To construct such predictive models, the key is to identify predictive risk factors and extract them from the data. Risk factors for heart failure have previously been studied, but with a stronger focus on primary prevention. EHRs typically document these relevant risk factors from clinical knowledge like literature, including age, hypertension, myocardial infarction, diabetes, valvular heart disease, coronary heart disease, and chronic kidney disease. The advantage of this knowledge-driven approach is the interpretability of the risk factors, which is grounded in established evidence and based on features that are reasonably well understood. This approach is also computationally appealing since the number of features involved in the model is usually relatively small, the order of 10 to 100. The disadvantage of this approach is that the resulting models may not adequately represent the complex disease processes that underlie the insidious emergence of heart failure. Not all risk factors have been identified, and many predictive features are yet to be constructed and tested. Another subtlety is that most of knowledge-driven risk factors describe high-level clinical concepts which do not directly map to the underlying EHR data. To construct and deploy a model in the operational setting, one needs to connect those knowledge-driven risk factors to the EHR data by constructing appropriate features, which is not trivial. Recognizing the limitation of a purely knowledge-driven approach, we can use a data-driven approach that systematically constructs and tests a large number of features. Our evaluation results indicate that a data-driven strategy outperforms a knowledge-driven strategy. Example, over 20% improvement in the area under the ROC curve. However, unlike the knowledge-driven strategy, the data-driven approach is often computationally demanding since a large number of features have to be constructed, selected, and tested. Another limitation of the data-driven strategy is with interpretability, since the resulting models often involve more features and more complex relations. Knowledge-driven and data-driven strategies reflect two ends of the spectrum. More specifically, a knowledge-driven approach is based on evidence of varying quality, guidelines, and experts' opinions, while a data-driven approach is solely based on the observational data. In this paper, we present a hybrid strategy that starts with prior knowledge, then extends to a more comprehensive model by including an additional set of features that both optimize prediction and complement knowledge-based features. We compare the hybrid approach to knowledge-driven approaches to quantitatively judge the feasibility of combining two complementary strategies for model building. In particular, we extend a sparse feature selection method, scalable orthogonal regression, to expand a set of knowledge-driven risk factors with additional risk factors from the data. Furthermore, the method is designed specifically to select less redundant features without sacrificing the quality, for which redundancy is measured by orthogonality measure added as a penalty term in the objective function. Our study utilizes EHR data extracted from Geisinger's enterprise data warehouse on all primary care patients. We construct 4,644 heart failure cases and 45,981 control patients, which in total consist of over 20 million EHR records from 2003 to 2010. The data contains diagnosis, medications, symptoms derived from clinical notes, and lab results. To showcase the power of the proposed method, we start with a set of known comorbidities to heart failure as the knowledge-driven features, then extend them, the comorbidities, with a set of optimal data-driven features from the EHR data. The evaluation metric is the area under the ROC curve measure. Our evaluation confirms that by including additional data-driven risk factors, classification performance is significantly improved with respect to the AUC measure in comparison to the knowledge-driven baseline. Moreover, most of selected data-driven features are clinically relevant to the development of heart failure, which further demonstrates the benefit of the proposed method. Feature selection. The purpose of feature selection is to identify a subset of K, most informative features from a pool of candidates. There are two major problems in feature selection. One is the measurement of how informative a given subset of features is, and the other one is how to obtain the optimal subset of features. Given a measurement of the quality of features, the feature selection problem becomes a combinatorial optimization problem. Because of its computational complexity, finding the optimal subset is usually solved by an approximation or greedy search. In general, there are two types of feature selection methods in the literature. Filter methods, where selection is independent of the classification or regression model, and wrapper methods, where the selection is tightly coupled with a specific model. Filter methods evaluate features one by one and select the top K features according to their scores. This type of scheme can be interpreted as a greedy approach by iteratively selecting one feature from the remaining unselected feature set. Within this category, one can implement it using two approaches: univariate filtering, for example, information gain, or multivariate filtering, example, minimum redundancy, maximum relevance. Wrapper methods provide an alternative way to obtain a subset of features by incorporating the classifiers, for example, directly approximating the area under the ROC curve, or optimization of the least absolute shrinkage and selection operator model. Methodologies for learning of non-redundant features have also been discussed in literature. For example, MRMR explicitly prefers low redundancy features, and non-redundant codebook feature learning method was also proposed. Beyond searching orthogonal features, our focus in this paper is to systematically address the redundancy between a pre-selected set of features, the knowledge-driven features, and potential additional data-driven features. Heart failure risk factor identification. Several risk prediction models have previously been developed for heart failure. However, they are limited in that populations used to develop the models included restricted, generally healthier populations enrolled in clinical trials or observational studies. In addition, the number of incident heart failure cases was relatively small, with the largest including only 500 heart failure cases. Also, the amount of data available to engineer features and develop the models was primarily limited to baseline variables captured at baseline. Our study includes nearly 10-fold more real-world patients routinely followed in a primary care setting with extensive longitudinal healthcare data. Therefore, feature selection is extremely important in our setting because of abundance of data and features that are potentially useful for predicting heart failure. We propose a framework for identifying and combining risk factors from knowledge and operational data. We first introduce the components involved in the system and then describe the computational core SOR feature selection method. Requires a knowledge base and clinical data from the knowledge base, risk factor gathering, and knowledge risk factors. And from the clinical data, data processing divided into potential risk factors and target condition, whereupon risk factor augmentation is done, and we then combine risk factors. Our analytic system takes two different paths to identify risk factors and merge them in the end to construct the combined set of risk factors. The system architecture shows the analytic components and the required input and output. The two paths indicate the analytic process for obtaining knowledge-driven risk factors and the analytic process for gathering potential data-driven risk factors. Finally, through the risk factor augmentation module, both sets are merged into the combined set of risk factors. Next, we describe each component in more details. The objective here is to identify risk factors from knowledge base or experts for a given disease scenario, for example, heart disease prediction in our case. This can be achieved using two approaches. The first approach, in it we take direct input from experts for a given disease condition through interviews. The expert inputs are compiled into a list of risk factor concepts, which are often high-level concepts of those relevant risk factors. These concepts are not yet risk factors that we can directly use for predictive modeling. We still need to map those concepts to the EHR data in order to abstract the instances of those risk factor concepts. For example, hypertension is a risk factor concept for predicting heart failure. However, we need to map hypertension to diagnosis codes 401.x through 405.x in diagnosis tables in the EHR database. We need to decide whether individual codes should be mapped to separate features, one-to-one mapping, or aggregated into single feature variable, many-to-one mapping. We found when sample size is large, as evidenced by the number of samples are much greater than the number of features, one-to-one mapping leads to better performance, since features are created at the finer diagnostic level and can often lead to better discriminating power. In this approach, ICD-9 codes 401.x will be treated as a set of different features from ICD-9 405.x. However, when sample size is small, as evidenced by the number of samples are smaller than the number of features, many-to-one mapping can lead to a smaller number of features and better prediction results, since a simpler model is more robust against overfitting. In this case, 401.x through 405.x will be mapped into the same features. Another possible approach to obtaining knowledge-based risk factors is to process medical guidelines and literature to extract known risk factors for a given disease condition. For example, some known heart failure risk factors are listed from published guidelines. These include hypertension, diabetes, prior myocardial infarction, known coronary disease, peripheral vascular disease, cerebral vascular disease, valvular heart disease, chronic obstructive pulmonary disease, and chronic kidney disease. We further divide valvular heart disease into aortic or mitral. Moreover, these factors also present the prevalence of those comorbidities in both cases and controls, where cases always have higher prevalence than controls. In addition to knowledge-driven risk factors, there are rich sets of features that can be compared from EHR data. We systematically construct features from different data sources in EHR, recognizing that longitudinal data on even a single variable, for example, blood pressure, can be represented in a variety of ways. The objective is to capture sufficient clinical nuances of heterogeneity of heart failure patients. A major challenge is in data reduction and in summarizing the temporal event sequences in EHR data into features that can differentiate cases and controls. In particular, we observe longitudinal sequences of measures based on diagnoses, medication, labs, vitals, and symptoms. The sparseness of the data will vary among patients, and we expect the sequencing and clustering of what is observed to also vary. Different types of clinical events arise in different frequency and in different orders. We construct summary statistics for different types of event sequences based on the feature characteristics. For static features such as gender and ethnicity, we use single static value to encode the feature. For temporal numeric features such as lab measures, we use summary statistics such as point estimate variance and trend statistics to represent the features. For temporal discrete features such as diagnoses, we use the event frequency, number of occurrences of a ICD-9 code. Besides constructing potential risk factors as features, we need to identify a target variable. In this case, we use the indicator variable to represent whether a patient has been diagnosed with heart failure by a certain date. The numbers of all features from different data sources can be large. For example, there are more than 9,000 distinct ICD-9 codes in our dataset, which could all become separate features. The focus to focus on potentially relevant features for heart failure risk, we perform an initial feature filtering by discretizing the features, then using information gained to rank those discretized features with respect to the target indicator variable. We keep the features with information gain score of 10 to the negative third, which include 387 diagnosis features, 403 medication features, 294 lab features, 30 symptom features. Note that many of these features are not in the knowledge-driven risk factors. Next, we explain how to merge systematically. The goal here is to combine knowledge-driven and data-driven risk factors systematically so that the resulting risk factors are interpretable as well as predictive. We start with knowledge-driven risk factors since they are more intuitive and well accepted for assessing the risk of a target condition. From there, we search for additional risk factors from the data-driven risk factors and extend scalable orthogonal regression model to perform the merge. The SOR model is specifically designed to ensure that the additional risk factors are highly predictive of the adverse condition of interest. There is little or no correlation between the additional risk factors from data and knowledge-driven risk factors, so that additional risk factors indeed contribute to a new understanding of the condition, which could lead to new potential treatment management options. And there's little or no correlation among the additional risk factors from data to further ensure quality of the additional factors. The SOR model achieves nearly linear scale-up with respect to the number of input features and the number of patients. SOR is formulated as an alternative convex optimization problem with theoretical convergence and global optimality guarantee. We compare SOR with several existing feature selection methods to show its scalability and stability. In this paper, we focus on the SOR extension that searches for an optimal set of data-driven features to augment knowledge-driven risk factors. On the other hand, knowledge-driven scalable orthogonal regression denote the data-driven features variable, sum, to an exponential. Each patient has a target variable, which in our case is whether a patient is a heart failure case or not. The other impact denote the target vector. In our case, features from diagnosis, medication, lab results, and symptoms